Okay, hello and welcome to the ILC Summer Webinar, CBD Pain Management in Ehlers-Danlos Syndromes and Hypermobility Spectrum Disorders. For those of you that are new to the ILC, my name is Sandy Smink. Today, we're going to hear from Dr. Arash Tagbai from Apollo Medical Cannabis. Dr. Tagbai is the medical manager of clinical affairs at Apollo and works to support patients to have an improved pain management and quality of life. We will also be hearing from Nicoletta Warnowski, who will be presenting an overview on EDS. Many of you will know Nicoletta, who is the ILC Health Resource Consultant. She worked for the Canadian government as a social researcher and as a health resource consultant for the ILC. She keeps abreast of current health research findings and participates on the Allied Health Working Group with the International Consortium on EDS and related disorders. She has co-authored the evidence-based rationale for physical therapy, treatment of children, adolescents, and adults diagnosed with EDS, which was published in the American Journal of Medical Genetics. During our time together, from a housekeeping point of view, our microphones will be muted to minimize background sounds during the presentations. We will also be recording the webinar. It will be published to the website to support continued education. For those of you that have submitted questions in advance, they will be answered during our time together today. At the end of the presentations, we will have a Q&A session. If you have questions that you would like to ask, please post them in the Q&A section at the bottom of your screen. So if you will, please join me in welcoming Nicoletta, who will be presenting first, and then Dr. Tagbai. Thank you very much. And Nicoletta.
Thank you, Sandy. Just to let everybody know that also not only the video, but also the text of my presentation will be posted on the ILC website. Thus, if you have questions and information and look for more details, please look at the reference list. And there you can click on the link of the articles that I use to write this document. So the first question, what is Ehlers-Danlos or EDS? EDS is a type of heritable connective tissue disorder, and there are 13 subtypes of EDS. Each of these subtypes is different. The most common subtype is hypermobile EDS, which affects people who are exceptionally flexible, such as dancers, gymnasts, and contortionists. The connective tissue is the glue that holds your skin, tendon, ligaments, bone, muscles, practically your entire body and your organs. EDS patients are born with defective connective tissues, and mutations in at least 19 genes have been linked to EDS. Some of these genes are associated with the body's production of collagen, which is a main component of connective tissues, giving structure and strength to its connective tissues, such as tendon, ligaments, and cartilage. These disorders weaken the body's connective tissue, which means that most people with EDS have highly elastic joints that dislocate and subluxate, which is partial dislocation. Hypermobility, like other diseases, varies with female hormones, estrogen and progesterone. Thus, there are more women than men with hypermobile EDS. It also varies with ethnicities, and it's found most frequently in Asians, next Africans, and least in Europeans. And it varies with age because it decreases as we get older. Next question, what are the current thoughts on prevalence? According to EDS Society website and Diana Jovin's recent book, Disjointed, chapter 3, the number of people living with hypermobile Ehlers-Danlos, hypermobile spectrum disorder is not known. However, according to international recognized geneticists, also EDS Society members, Doctors Castori, Franco Mano, Hakim, and Malfet, and also the recent book Disjointed, about 1 in 5,000 people around the world, thus Canada too, lives with some form of EDS. Now, how is hypermobile EDS diagnosed? The EDS Society recommends their diagnostic criteria checklist for doctors across all disciplines to be able to diagnose hypermobile EDS. For the link to the diagnostic criteria checklist, please see reference number 18. For hypermobile EDS, neurological manifestations such as craniocervical and cervical instability, tetracord syndrome, Chiari malformation, cerebrospinal fluid leak, Tarlov cyst, special neuroimaging is required, such as upright MRI and rotational CT scan. Unfortunately, these are not available in Canada. Now, what are the symptoms? Because hypermobile EDS affects multiple organ systems and has multiple coexisting conditions, the patients can present the doctors with an unusual group of symptoms, such as neurological, which include pain, migraine, neuropathy, which is caused by nerve injury, which is caused by trauma from dislocation and subluxation, sensory loss, droopy eyelids, involuntary movements, fatigue, dizziness, imbalance, falls, sleep disorders. Musculoskeletal symptoms include pain, loose joints and ligaments, early onset of osteoarthritis caused by dislocation and subluxation, muscle atrophy, rupture, ligaments, tendon, and muscle. Digestive symptoms include pain, irritable bowel syndrome, reflux, hernias, diarrhea, constipation, nausea, difficulty swallowing. Urogenital symptoms include pain, incontinence, neurogenic bladder, frequent urinary tract infection, prolapse uterus and bladder. Cardiovascular symptoms include pain, extremities blood pooling, phlebitis, defective heart valves, enlarged aorta. Oral symptoms are pain, jaw dislocation, temporomandibular disorders, shifting teeth. Ocular symptoms are retinal tear, vitreous detachment. Vitreous is the middle of the eye, and its detachment leads to early onset of macular degeneration, which is the central vision loss, and pain. Under autonomic nervous system, we have dysautonomia, postural orthostatic tachycardia, fainting, and pre-fainting. Under immune system, we have mast cell activation causing reactions to food, temperature, chemicals found in food, air, and drugs. Dermatologic symptoms are pain. Again, as we've seen, pain is everywhere. Skin that bruises easy, stretches, and wounds heal slow. These multiple symptoms make it difficult to diagnose hypermobile EDS. Thus, most of the time is undiagnosed, underdiagnosed, misdiagnosed, and thus it takes years and decades to receive the correct diagnostic. Another symptom is anxiety. And according to Dr. Pochinki, a member of the EDS Society, the anxiety in EDS patients, it's caused mainly by physical triggers, such as pain, which is neuromusculoskeletal visceral, also by pain, by fatigue, dehydration, drop in the blood sugar and blood pressure. So my question here is to everybody, patients, family, and health professional is, who would not be anxious if they dislocate and subluxate during regular daily activities and night sleep, especially the craniocervical joint where the brainstem is. And the brainstem is the headquarters of autonomic function, such as walking, talking, swallowing, opening eyes, urination, defecation, heart, and lung functions. So who would not be anxious? Symptoms vary from mildly loose joints to life-threatening complications related to brainstem and spinal cord injuries that are caused by craniocervical and cervical instability, Chiari malformation, tetracord syndrome, cerebrospinal fluid leak, Tarlov cyst, which require neurosurgeries, that unfortunately are not available in Canada. Thus, many EDS patients had neurosurgeries in Maryland, such as craniocervical and cervical fusions and tether cord. The last question, what are the treatments? For details, please see references number 13 and 17. And we have a question about cure, and I will answer this when my turn comes in Q&A. But in general, treatment needs to be adapted to the EDS subtype and to the individual. For those with hypermobile EDS, the most common subtype of EDS, exercise is key for its management because stronger muscles stabilize weaker joints. And in this way, you prevent dislocations, subluxations, falls, injuries, and more pain. Patients with EDS, especially those with hypermobility, need to practice posture control during daily activities and night sleep, and also avoid high-impact sports and spinal manipulation. Medications, such as medicinal CBD, is also helpful for pain, neuropathy, migraine, inflammation, IBS, sleep, anxiety, involuntary movements. Dr. Arash Tagvai, Manager of Clinical Affairs at Apollo Cannabis Clinics, will present an overview of medicinal cannabis. Back to you.
Thank you so much, Nicoletta, and hello to everybody. Nicoletta was incredibly informative. Thank you so much. I think that when it comes to EDS, one of the things that it's important to note is that this is a condition that can literally affect every single system in our body. Collagen is the most abundant protein in the human body, and if we have any kind of defect in the synthesis of collagen, it will undoubtedly affect multiple systems. So I have a presentation that I'm going to share my screen with and get started. So as mentioned, my name is Arash. I am the Manager of Clinical Affairs at Apollo Applied Research. We are a cannabis clinic that initially started in 2013, based in research, and then has since grown. I graduated medical school in 2017, and when I completed my medical school, I decided to come back to Canada. My clinical rotations were in the Atlanta Medical Center in Atlanta, Georgia. I also had some time in the Grady Emergency Room, which is the #1 trauma unit in the Southeast. After I finished my core rotations, I went to Cook County Hospital in Chicago, Illinois, and that was where I also worked in the emergency room, another very high trauma unit. While I was there, cannabis was looked at as a recreational illegal substance in both hospital settings. I never had any experience with cannabis before coming to Apollo. So when I came to Canada initially, again, I applied to work at Apollo Applied Research, and I also worked at a family medicine clinic. I found that the patients were happier at Apollo. I found that the actual work was far more satisfying to me. There was patients that were learning and the patients that were understanding their condition, because along with learning any new medication, you must learn your system and condition. So that's a little bit about me and a little bit about Apollo. I was raised in Calgary, Alberta, and I also went to the University of Calgary. So that's a little bit more background about me. So I mentioned Apollo was started in 2013. This is a research-based institution. It was initially a group of small group of physicians that got together and had their patients consistently asking them, "Hey doc, can I get a prescription for medical cannabis? I heard so-and-so was using it and it was successful." And they all turned to each other and said, "Well, we know nothing about it." So they took a small group of patients and they conducted their first study, and it was basic chronic pain observational study. Word of mouth is a powerful tool. And before they knew it, they had many, many more patients coming knocking on their door asking for a similar type of prescription to combat all things chronic pain, to also help with sleep. Sometimes they were getting patients that were incredibly cannabis naive, and they were also getting patients that were incredibly cannabis experienced, teaching the doctors what helps them and what works for them. So it went both ways. It was incredibly informative, and they basically decided that this scope of practice deserves its own space. And therefore Apollo was born. Now, fast forward to 2021, we now have well over 120,000 patients rostered in our EMR. We see patients across the country, coast to coast. Although our practice started in Toronto, Ontario, again, we have expanded to all provinces. Our team is now made up of physiatrists, anesthesiologists, we have pain specialists, psychiatrists, very important for mental health these days, family doctors as well. And of course, amongst all of our physicians, we have a team of researchers and academics and statisticians that pay attention to all of the epidemiology, all of the information that we gain from our everyday practice. And this picture here on the left is our clinic, one of our clinics. So these are some of the research documents that we have, some of the research studies that we've conducted. Some of the documents are still in peer-to-peer review, so I won't say too much about it. But we have been published in the American Journal of Chronic Pain and with our chronic pain study. This was a 12-month retrospective study that we conducted. The number that we love to focus on in our clinic is the 95% reduction in opioid use that we observed. In medicine, generally speaking, very generally speaking, the number to aim for in terms of change is about 30%. So if we can reduce pain severity by 37% and reduce interference with daily activity by 43%, we would consider that a successful study. Our PTSD study is something that we've been very focused on. Veterans from all over the country use medical cannabis, and it is benefiting them, but not necessarily well understood as to how. So we really focused in on that. Our results are still preliminary, but we have, again, that golden number, well over 30% of reduction in PTSD symptoms. When it comes to PTSD, there's such a fierce neurological component, not just psychiatric, that people lose the ability to function. They have slowing in their neurocognitive abilities. So again, we have found that social functioning, emotional well-being, and energy levels have increased with our study. The last one on this slide is our driving study. It is still going on. This is the largest study that has been conducted in the arena of medical cannabis. We worked with the University Health Network and also the Ministry of Transportation. And it was a very, very interesting study, just measuring the cognitive effects of medical cannabis on driving. Also discussed in chapter 20 of Disjointed. Thank you so much for the book, Sandy or Nicoletta, or whoever sent it. I really appreciated the read. The chapter on medical cannabis was very, very interestingly written. It is extremely objective, which I adore. And I thought the physician did an excellent job of recognizing how and when medical cannabis should be used. And what he ends with is one of my favorite lines. Like any other medication, we must form a strategical plan to use it to address chronic pain. And of course, everything is involved and individualized. That's something that we love to kind of promote in our clinic. Who are our patients? Initially, when I was doing these presentations, people would expect me to bring samples or have snacks or have something that I can offer the audience when it came to medical cannabis. Guys, it's very important to note, our office is a doctor's office. There is no cannabis present. It is given, patients are given a prescription that gives them access to licensed producers, which I will discuss later. And we have a very similar demographic to any family doctor's office. So again, I would hear, well, if I go there, is there going to be some Rastafarian music in the background and a puff of smoke in the middle of the room? No, guys, that is not the case. We are, again, a typical doctor's office. This is what you would see in our West Mall location when you walked in. There's a waiting room, there's consultation rooms, and there are education rooms as well. So important to know. Oh, also one more interesting thing that I like to discuss. Ever since 2017, when when cannabis was legalized, the age group of 19 to 35 has shown not much change in terms of consumption of cannabis in general. They were doing it before, they're still doing it. But the 55 and over audience, or the chronic pain audience, has skyrocketed. This has now become something that you can discuss with a physician or discuss with any kind of healthcare professional. And for that reason, people have ventured far into it. So this is our Apollo process. I've boiled it down into, we've boiled it down into a one-pager to make it very clear. Initially, you will book an appointment, just like any other doctor's office. The appointment will be conducted with a healthcare practitioner. We have physicians across the country. We also work well with nurse practitioners. After that, you will receive a personalized education and treatment plan. This is Apollo's bread and butter. This is where you will spend the majority of your time during an appointment, okay? It must be understood how to consume the medication, understood what to look for, both improvements and side effects. All of that is discussed, and the patient has a 7-day week, 9 to 5 helpline that they can call at any time as well. Final step, step 4, the medication is delivered directly to the patient's home. As I speak to you now, there is no place in which you can take a medical document and attain medical cannabis. You can walk into a recreational cannabis store, but of course, then you are at the mercy of what they like to call a bud tender, someone who understands cannabis, but doesn't necessarily understand the health behind it. or the health conditions that people would have and health concerns and questions people would have regarding medical cannabis. I mentioned licensed producers previously, but I'll touch on it again. Once a prescription has been generated by your physician, once the doctor decides that this patient is on no other interacting medications, there is no risk associated with this patient using this medication or an appropriate risk, then they will send a prescription to what is called a licensed producer. Licensed producers are organizations that are approved by Health Canada to grow cannabis for medical use. They have authority to grow dry cannabis, oils, sprays, capsules, vaporizing cartridges, edibles, and now even topicals. Okay, so the market has expanded a lot since even just the past 2 years. When I first started working at Apollo, there was about 150 licensed producers. There are now well over 600 licensed producers. So we like to say that they are popping up like weeds, no pun intended. They're very popular in terms of what they can offer in strain value to patients. We allow our patients to go to any licensed producer, especially if they have prior experience with a licensed producer. But if they have no understanding of licensed producers, they've never used cannabis in the past, then what we would do is assign them one. And we have a list of licensed producers that we like based on patient feedback, based on result of medication, and of course, the all-powerful availability of medication. These licensed producers grow 2 plants. Well, they grow 3, 2 in which I will discuss on a slide, and then the third one I will just explain to you. The first plant that licensed producers grow are called Sativa Plants. Sativa, S for sun. That's how we remember it. It is energizing, it's uplifting. If anybody ever sees a sativa plant, a full-grown sativa plant, you could tell it's a very powerful and strong plant. The base of the plant is, basically the same diameter or radius of the end of a baseball bat. You wouldn't be able to pull the plant out of the ground with your own hands. These plants were initially discovered in South America. They grew wild jungles of feral sativa plants. And initially they were considered a nuisance. So farmers were chopping them down. And one day somebody noticed that it has this skunky scent to it on the end of a plant. There's a bud. And well, he plucked that and he started to chew it. And he told all of his friends about it. And all of his friends and all of that community unanimously reported that they had more energy, less back pain, and a better mood. They understood very early on that there was a powerful component to this plant and there's medicinal value. But of course, they did not understand the complexity of it. The second plant that I'll discuss here is called the Indica plant. Now, indicas were discovered in Asia. These guys are short, stubby little plants. They grow very low to the ground. They're very sensitive. Sometimes entire crops of these plants are lost just because of increased acidity or too much sunlight or too much water. So they're everyone's houseplant nightmare, right? They'll pass on you without you knowing. Nonetheless, indica plants are known to be calming and relaxing. The memory trick for this guy is indica in the couch. So a physician may turn to this strain if looking to address a sleep disturbance with a patient. Now, keep in mind, I have not yet mentioned CBD or THC. We're just talking from a plant standpoint. These plants are genetically identical, but phenotypically different. The same way everybody on this call is genetically identical, but phenotypically different. Phenotypes are what decide our hair color, our bone density, our eye color. All of the subtle changes in a species are decided by phenotypes. And again, these plants, because they're genetically identical, can be cross-pollinated. And again, I'm not a botanist. I don't know all of the details about the plant life, but what I know is that they can create what is called a hybrid plant, which is a combination of the strong sativa and the properties of an indica, and they put them together and they call a hybrid. So many people use medical cannabis in a hybrid form, and they're quite successful with it. The medical compounds. So finally, we get to the meat and potatoes of medical cannabis. First and foremost, CBD. There should be no person on this column that hasn't heard of CBD by now. It's quite popular. I found it very interesting in the book that was sent to me in Disjointed. The physician there mentions that CBD isn't really the medication of choice. CBD is where we start many patients, but THC is where we observe true results. And he almost hopes that it blows over the popularity of CBD. I don't know if I agree with that because we observe a ton of benefit in our clinic. Nonetheless, CBD and THC have very similar actions in the body. They connect to the same receptor system that I'll review here in a moment. But properties of CBD, things that we have documented in clinic, its analgesic properties are by far and away its most important. a painkiller. A lot of people use it to replace Advil and Tylenol. If you have chronic pain, then you should use the medication more regularly. And again, those people report to us that they have a decreased severity and decreased incidence of pain flares. That's something we see all the time. Keeping in mind it's the non-psychoactive component. There will never be a time in which you feel like you're floating in the clouds, or things are extra funny, or you have an appetite that you can't control. It also has antipsychotic properties, which our psychiatrists love to take advantage of. And we're starting to see more and more referrals from neurologists with patients who are on anti-seizure medications, anti-epileptiform medications, but want to kind of maximize their patient's treatment plan with the introduction of CBD to use in adjuvant alongside, in conjunction with traditional medication. Also, the reduction in anxiety, Nicoletta mentioned, physical triggers are the main cause of anxiety in EDS. Let me tell you guys, physical triggers are the main cause of anxiety in any chronic condition, right? A fibromyalgia patient who sits with no activity and has so much pain that they cannot sleep, they cannot eat, they cannot focus on anything but the pain, becomes exhausted. And of course, CBD plays a significant role in mental health. I don't want to take too much time here, but the effects of the pandemic have also shown a lot of mental health coming to surface, and we've been dealing with that quite a bit as well. THC, this is the next chemical component that we take advantage of, and a lot of medical professionals regard to as the main medical component. So I refer to modern medicine a lot, and I don't mean to throw any shadow, but from our observations, both CBD and THC are equally effective. Just depends on the individual. Keeping in mind, it also has analgesic properties. That's a fancy Latin term that means painkiller. It also has an anti-inflammatory property to it. If used for 4 to 6 weeks regularly, it can significantly affect inflammation. It is also the main component to be using to address insomnia. If someone's sleep disturbance is because they just can't shut off their mind at night, well, then maybe CBD will help enough. But if we have a person who is struggling with restless leg syndrome, also has anxiety, also has chronic pain, well, guess what? We should probably use both THC and CBD, and we will get there slowly. Last point I'll make about THC before moving on is that a lot of people are worried about this, the appetite stimulation. Hey, Arash, in a world in which everybody's trying to lose weight, why would I ever take a medication that's going to stimulate my appetite? And we have to explain to patients that it is dose dependent, and it also plays a significant role with some patients. Medical oncology, chemotherapy. Anybody who has gone through that will tell you that they have next to no appetite and a complete inability to hold food down. If we can give them the correct dosage of THC in a safe environment, it can stimulate their appetite and it can really help their road to recovery. Again, dose dependent, guys. Keep that in mind. Also important to note, it's not a metabolic requirement. If you eat THC, you don't have a higher metabolic rate. You simply are stimulated in the nuclei of the brain that tells us to eat. So if we're mindful, cognizant of that, we can get ahead of it. Trichomes. I added this slide because I thought it was very interesting. You guys may or may not agree, I don't know. But this is a microscopic photograph of the plant. Once cannabis matures, at the very end of the plant, these tiny little oily projections will come out, and they're called trichomes. This is literally where the CBD and THC live. This whole song and dance, the whole appointment to attain a prescription, to go to a licensed producer, to choose a strain, and to use the medication is based on these little guys right here, the trichomes. So a licensed producer will take 5 to 10 grams of cannabis, and they'll heat it, and they'll vibrate the plant in a process that is called decarboxylation, and they'll melt these little oils off like butter. And they'll use that CBD and THC in a concentrated form and then dilute it in coconut oil or olive oil, whatever oil is chosen by the licensed producer and approved by Health Canada. Because these trichomes are fat soluble, and we are fat soluble, this medication plays an important role in the human body through what is called the endocannabinoid system. If we recognize that mannequin on the right side, CB1 is the THC receptor, CB2 is the CBD receptor. And in medicine, when a receptor is everywhere, we have a fancy name for that, we call it ubiquitous. It just means everywhere. So keep in mind, these receptors are in multiple systems in multiple areas of the body, and this explains why so many different conditions can be addressed with cannabis. Now, I want to rewind a little bit. Our body naturally produces substances that are very similar to CBD and THC. They're called 2-AG and anandamide. I don't want to get too technical. It's one of my biggest critiques. But the endocannabinoid system, endogenous in cannabinoids, is what we kind of tap into with CBD and THC, and those are called phytocannabinoids. So I say again, THC and CBD mimic substances that we already have in our body in a system that is already in place in our body. There are other components to medical cannabis. There are synthetic versions of it. There are nabilone and Sativex, not to be confused with sativas. And for any given reason, for reasons that we cannot explain, the synthetic compounds of cannabis are not nearly as successful as the phytocannabinoids. Patients will tell us after 3 days of use, they've become fully tolerable to it. They have to double or triple their dose to attain the same results, and it just doesn't work for them. Nonetheless, important to note, the endocannabinoid system can be further broken down per system. Nicoletta mentioned in her presentation that IBS, irritable bowel syndrome, is something that is present with EDS often. Guys, keep in mind, anytime collagen is weak, that system will have the inability to push or constrict when necessary. So if a person with EDS, I'm just saying as an example, if a person with EDS has a lot of defective collagen in their large and small intestine, then they may have trouble pushing food along the digestive system. And if food sits, well, then food rots. And when food rots, we have an immune response to that. Large and small intestine is a place in which the immune response can be caused due to an inability of collagen constriction or muscle push. Same with nausea in the stomach, right? There are several sphincters in the human body. One of them is the pyloric, and that one will constrict and hold food in place. Well, guess what? If the collagen is loose, then that might open up a little bit again. And then we have acid shooting up, and that causes reflux for the individual. So there are many, many different systems that cannabis can address, and it'll always be condition dependent. Another thing that's important to note when it comes to Ehlers-Danlos syndrome is the involvement of the both central and peripheral nervous system. Everybody always thinks, you know, THC is in my head and CBD is in my body. That's not necessarily the case, guys. Both CB1 and CB2 receptors play an important role. When it comes to anxiety and depression, we treat both CBD and THC like any other class of mood stabilizing medication, which is it must be used for 4 to 6 weeks consistently, because those receptors are deep, before we understand exactly how it can or cannot help. I mentioned the immune system previously, but I'll mention it again here, way down at the bottom. The immune system is CB2 is also something that's, the CBD receptor is actually on the immune system. So again, lots to discuss on this slide. We can basically explain any condition, including many of the symptoms of EDS with this slide, and I'm happy to come back to it later on as well. So therapeutic uses. I always kind of criticize myself when I get to this slide because I feel like I've discussed a lot of this already, but maybe if we want to pause briefly to discuss anything on here, I would potentially say neuropathic pain is a very important one for us. Nobody ever comes into the clinic and says, hey doc, I got neuropathic pain. They say, well, I was diagnosed with diabetes mellitus 10 years ago, and I now have numbness and tingling in my fingertips and toes. The nerves that are the furthest away from our brains, right, fingertips and toes, are going to be the ones that are sacrificed first. Also, neuropathic pain can be seen with many other conditions on this list, multiple sclerosis and EDS. Okay, let's not forget, EDS has the involvement of neuropathic pain, and it also has the involvement of musculoskeletal pain. As Nicoletta mentioned, exercise is important. If you strengthen the muscle, you will strengthen the joint. Exercise is also important because it causes an increase in vascularity, increase in flow, circulation. The almighty cell, known as the fibroblast, is the guy who makes collagen in our body. And if there's any kind of defect in collagen synthesis, well, the more of them there are, potentially the more we can fix, the more we can help. And I get carried away in my own head, but that's basically the same explanation as to why it takes longer for people with EDS to have wound healing occur correctly, right? A decrease in collagen synthesis or correct synthesis. Again, guys, I'm happy to come back to this slide afterwards if you guys wish. Now, here I am again, getting ahead of myself, but how can cannabis help EDS? So I mentioned our chronic pain study and some of the results that we saw, but this is a further breakdown of it. We had 751 patients registered in our chronic pain study. And again, it was 12 months. It's been published. I'd be happy to share that publication with you guys at the end. We also went out and found other surveys and other publications to kind of verify what we found, to make sure we were doing the right thing, and if anybody else was able to replicate our results. And we actually found better results than we had. So in 2018, this survey had approximately 200 more patients than us, and said that there was about 74.7% effectiveness in relieving symptoms of chronic pain. This study goes on to mention that they had chronic pain from multiple factions of medicine. So there was rheumatology, there was your basic osteoarthritis versus rheumatoid arthritis, and then there was, of course, fibromyalgia and any other chronic pain condition. So they didn't have any boundaries, which is great. If we focus in and hone in a little bit more on the exact symptomatology that we can control with medical cannabis and EDS, this would be a short list, but right at the top, sleep, okay? It's important to note, anybody who's in chronic pain is going to graduate into what is called chronic fatigue. I'm in pain, so I don't sleep, and if I don't sleep, the next day I'm in more pain. And fibromyalgia always comes to mind, but EDS at its worst can also have a significant impact on sleep. And remember, we want to break that cycle. If a person is averaging 2 to 3 hours a night and we give them all of a sudden 6 to 7, well, that's a huge victory for that patient, and that's a large increase in functionality. I want to make something very clear, guys. I've mentioned EDS in multiple slides already, but one of the main factors that controls how EDS presents in the individual is called variable expression. Some people diagnosed with a condition will express that gene in a very small level and have minimal symptoms. Other people will express it in every system in their body, and they'll have multiple systems. It'll be far more devastating to that individual. So when it comes to chronic pain, we have to first understand, is it musculoskeletal? Is it wear and tear? Or is it neuropathic? The patient is sitting there doing nothing but experiencing pain. And that is something that the healthcare professionals at Apollo are really good at. They'll be able to distinguish the difference between the pain based on when it presents, based on the nature of it. Does it travel? Is it like a light switch, on and off? Well, those are all things that we would discuss. Mental health, I've already mentioned anxiety. There's also the presence of depression with anxiety, and there's also the effect of insomnia on mental health. So again, all three of those get wrapped up into one. A psychiatrist will focus on a patient's sleep cycle. They'll even sign them up for a sleep study to ensure that they're not wrong with their calculations, because we rest and we heal at night, and that includes the brain. And if an individual is constantly not sleeping, well, then the brain has no opportunity to reset, to clean itself up. And that'll always worsen the level of neurotransmitters and cause far worsening symptoms of anxiety and depression. I don't want to get too technical, guys, but we can help. Reduction in nausea, I've already explained how the digestive system can react with EDS at its worst, and also how sphincter control, the tightness of that muscle, can be questioned by EDS. Back to medical cannabis, methods of consumption are important to discuss as well. A lot of people think, well, I don't want a cannabis prescription. I don't want to, smoke anything. Guys, we do not promote smoking in our clinic, period. I pause for dramatic effect. We always start patients now with oils and soft gels. If a patient for any reason is reluctant to take medical cannabis in an oil or soft gel form, then we can potentially discuss gummies and chocolates. No doctor will initiate treatment that way. Important to note. But we sometimes have people who are suffering from Alzheimer's or are much older and have dementia, and they will reject any medication or capsule, but they'll be happy to take a piece of chocolate, and it reduces their aggression, it helps their sleep, and they naturally, or not naturally, but they afterwards look far happier. It looks like their pain is not nearly as severe, even if they're non-communicative, right? The observation of chronic pain is recognized in May. Nonetheless, that's where they play a role. If you are in the scope of inhalation of medical cannabis, your physician would consult you on the use of an appropriate device. Guys, keep in mind, these are Health Canada approved vaporizers. You would put dry cannabis into this machine. It would heat the plant to the point of dehydration. There's nothing being burned, nothing is being combusted. And then, of course, you will inhale the medication similar to an asthmatic using salbutamol or a bronchodilator of any sorts. The medication is much faster when inhaled. One very important note when it comes to inhalation, not all who are inhaling are attaining a high. There are full strains of CBD available from licensed producers now. We have a patient that is in their 70s that will turn on a vaporizer and inhale CBD to get rid of their joint pain from going to the grocery store, and they need it now. Okay, they want to put their stuff away. They want to move on with their day. So it's important that patients are well educated in that area. And it's also very important for us to again, promote. We do not want anybody smoking cannabis. We do have patients who smoke it, and then they come to our clinic, and then they're educated on a vaporizer, and they come back, hey doc, that was a great idea. Thank you so much. I'm not coughing nearly as much. I'm not nearly as in much pain from using cannabis, which is the only way I can sleep. And then again, of course, the physician is running through his mind, is this person causing themselves more harm than they're helping? Let's get him on a vaporizer. Let's talk to him about capsules and oils as well. Topicals are a very hot topic now. We still have a lot of people that have the stigma towards medical cannabis. I don't want to touch that medication. I don't want to touch that. It's still a drug, but I'll rub it on my elbow every now and then because that hurts. Or I'll put some on my neck when I get a migraine. That helps. Remember, guys, if ever you use a topical version of any medication, it can potentially benefit you, but will not nearly be as effective as the using it systemically. So I've already mentioned oils and capsules. I won't say that again, but what's important to note is that anytime cannabis is consumed by mouth, it goes through what's called first pass metabolism. It takes about an hour and a half to 2 hours to kick in, here, and it should last anywhere from 4 to 8 hours. So longevity of pain, which is also mentioned in this book, right? We have to find out what type of pain the patient is suffering from. If they have acute pain or if they have chronic pain. Chronic would be better with the oils and capsules. Acute could be better addressed with inhalation. Again, that's left to decide on the consultation with the physician. I've already also discussed the rapid effects of inhalation of medical cannabis. Again, we only suggest Health Canada approved devices in our clinic. And sometimes we get all sorts of feedback from patients that were thinking they were using high levels of THC that now recognize they were not. And they were getting their cannabis from a non-standardized source, which is a non-licensed producer. Side effects. Guys, we've talked a lot about the positives of cannabis. We must discuss the side effects as well. What I was thinking about initially when we put this list together is that the possible list of side effects can all be found on the side of a Tylenol bottle or any other thing that's found over the counter. Keep in mind, these are all related to THC. The side effects of overdose of CBD would be a slight headache or an upset stomach. But again, with high levels or incorrect dosage of THC, there can be dizziness, there can be some drowsiness, which some people aim for. Taking a medication for sleep assistance that causes drowsiness is a positive, but not for everybody. So of course it can still be considered a side effect. And accentuatingly high amounts, over 50 or 60 milligrams of THC can cause anxiety as well. Keep in mind, the world of medicine starts THC at 2.5 milligrams. So it's a microdose compared to the recreational world who uses 40 or 50. Some of the more uncommon side effects are probably the more commonly asked about side effects. The panic attacks, the paranoia or psychosis. I heard so-and-so tried it down the hall and they went crazy. Guys, there's never ever been a case of documented psychosis with a patient that doesn't have a previous mental health history. What do I mean by that? If an individual was diagnosed with bipolar, but they are now stable with medication and monitoring by a psychiatrist, and then they take recreational THC, well then yes, they may cause some anxiety, they may trigger other symptoms of psychosis, but that is not ever going to be the case at Apollo. No patient with a previous mental history would receive THC at all, actually. We would start them with CBD, and like any other medication, we can restrict that from the patient. Guys, I don't want to take too much time to discuss the opioid crisis in Canada. We lose hundreds of Canadians to this every year. Just very quickly, and the reason why I snuck it on here in a very sneaky way is that cannabis does not have receptors in the brainstem. As Nicoletta mentioned earlier, the brainstem is responsible for autonomic function, things that we do without thinking about. Breathing is one of them. Opioids can cause respiratory depression, a slowdown in autonomic function. It's incredibly sad because what happens is these are people, just normal people, who are looking to attain some better sleep and some pain reduction. And their doctors run out of treatment options, and then they eventually get to opioids, and the doctor tells them very clearly, do not mix this with any other neurological suppressant. And he says, sure, doc, I will listen, I'm a good patient. Fast forward 6 months, fast forward 12 months, the patient becomes comfortable with the medication, which is great. That's not a negative. but they eventually start to do other things and then come home and take this medication. And one day they go to a party and they have a couple of alcoholic drinks. They come home, they take their medication because, again, they want to function the next day. And now you have two neurological suppressants, not just one, and the patient will simply stop breathing. And it's incredibly sad because they are found afterwards. And this is a fully functioning individual who was unfortunately, without knowing, on too many neurological suppressants, and they stopped breathing. Now, the reason why I bring all this up, this is not a presentation on opioids, nor do I mean to throw shadow at modern medicine. The reason I bring it up is because cannabis does not have those receptors. It doesn't have the ability to slow respiratory breathing. So there is no risk of respiratory depression with medical cannabis, which makes it infinitely safer than any of the traditional pain management options that are out there. This is another study that we love to cite. And again, we were able to kind of mimic these numbers in our clinic. This is the European Journal of Internal Medicine, published in 2018, which is very recent. It states here that 901 patients were studied with medical cannabis, and their results were very similar to ours in terms of side effects. Right? Number one being about 9.7% felt dizziness, and dry mouth, and then somnolence. So similar order of ours, we had drowsiness. They used somnolence, which is probably a better word. And again, it was also very interesting for us to dive deeper into this study. And we found out that it reported that patients had, this demographic, this 901 patients had about a 53% incidence of falls prior to the initiation of cannabis. And then that number decreased to 21.9 following treatment with cannabis. So we were all left kind of scratching our heads. How is it possible that a medication whose number one side effect is dizziness is causing less falls? And we had to get into the fine print, right? Read all the stuff that they don't necessarily publish right off the front. So what we found is that this group of people had a high incidence of what is called polypharmacy, which means many medications. 5 or more medications is considered polypharmacy. These people, most of them were on 5 or more medications. And with the use of one medication for sleep and one medication for pain, well, they were able to get rid of those two and just use cannabis instead. So they came out of the class of polypharmacy. They were able to reduce other medications, which we've also found in clinic and been able to prove in our research. Because of that, there's a decreased incidence of falls. And I thought that was very interesting. Dependency is an important question. If I use this, will I be addicted? And the answer is, well, no. But there is studies on it that say medical cannabis has a 9% dependency rate. We had to find something academic, and I really don't love this slide, but what's interesting about it is that it was published in 2001, which is the year that medical cannabis was legalized. Guys, I pause again for dramatic effect. Medical cannabis has been legal for 20 years, but only since 2017, when it became recreationally available, people started looking more into it. So in this study, it says 9% of people who smoked cannabis recreationally, not used it medically, 9% had a dependency to it. When it was cut off, they had symptoms of generalized anxiety disorder and wanted to have the cannabis again. But that doesn't necessarily mean there were physical symptoms of dependency. On this list, there are a few things that I do not believe we belong in the same arena of, right? Cocaine and heroin are very hard street drugs. That's not us. Alcohol, there's a very interesting one. I get a bit passionate about this. This is a substance that we celebrate with, very socially acceptable. Any organization that doesn't sell alcohol is, frowned upon. What? You can't have a drink with your dinner here? That's strange. But nonetheless, the dependency symptoms of alcohol kill people. Alcohol causes a flux in our electrolytes, and it causes a disruption in the protein membranes. And so a person may be hyper or hypokalemic, meaning too high or too low levels of potassium or calcium, or some of these big electrolytes that can slow everybody down. If a person stops drinking, they may have irregularities of their electrolytes in their muscles, and that'll be called a cramp. It can occur in the brain, and that's called an alcoholic dependency seizure, okay? It can also have atrial fibrillation. They will drop dead based on this. So again, alcohol is a very dangerous substance that a dependency is hospital monitored. The substitution effect is something that we can discuss in Q&A if necessary. I've mentioned several times how we were able to reduce prescription medications, and this was another study that we found. Also, a couple of the advantages for medical versus recreational cannabis. Everybody comes to us and says, well, I was already using cannabis. Why come to Apollo now? Well, keep in mind, guys, There's insurance programs, there are discounts, and it is fully tax deductible, purchased under a prescription. Also, your connection to a standardized source is unequivocally important. Also, a few more things about us. We do not require referral. We are Canada-wide, and we do have, from pediatric to palliative care, we like to call it, cradle to grave availability for our patients based on the physicians that we have now. Q&A. So here we are. Okay, and there's already a few questions, or there's 7 in the chat. Let me just take a quick look. So Tanisha, you had mentioned which receptor is which. CB1 is THC, CB2 is CBD. And remember, they are ubiquitous in the body. They're both everywhere. THC has a much higher affinity, meaning it's more attracted to those receptors. It's about a 20-to-1 ratio in terms of affinity, which is how we dose it as well. If the patient is successful with approximately 20 milligrams of CBD, we should use anywhere from 1.5 to 2 milligrams of CBD. So we want to keep that measurement in mind. Please keep your computer muted. Can cannabis reduce spasticity? Excellent question. Now, spasticity is going to be a difficult one to kind of address. But what we know is that THC is the main component that can help with that. It does, we've seen in clinic a reduction in the severity of spasticity. And it also goes in line with myoclonus or any other neurological condition in which there is strong contraction, right? And we can kind of help weaken that contraction a little bit. Again, THC slows down the neurological system in regards to pain reception and also functionality. So we're going to keep all that in mind when using that. That is something that we would have to trial for some time before we can say, you know, yes, it's working. And again, it's going to be an individual basis.
Thank you.
Tanisha Weeks also asks, should I stop muscle relaxants while taking a THC oil, or how long apart should I administer them? Really good question. We like to have medications that have the similar function of THC separated by approximately 4 to 6 hours. Also, and I don't want to promote this without knowing your entire past medical history and an updated HPI on you, but if a patient is taking multiple medications, well, then we don't know necessarily who's doing what. So if the muscle relaxant is used PRN, which is as needed, if we put it away for 2 weeks and just use medical cannabis, we will have a better understanding as to how it can help. That way we can say, well, I know, I'm just going to make these numbers up. I know medical cannabis can reduce my symptoms by 30%. The muscle relaxant gives me another 30%. So combine them, I get 60. We just have to learn those numbers. Good question. Guys, sorry, the chat box is quite small. So if I've missed anybody, please resubmit your questions. Thank you so much. Great information. Oh, thank you, Tanisha. Appreciate the compliment. You are too generous. Hold on here, for people who have chronic kidney disease, it is not recommended to take Advil because of the damage it causes the kidneys. How about cannabis? Very good question by Zara. This is new. I will speak on the metabolism of cannabis. Cannabis goes through what is called a P450 system. I don't want to get too technical. P450 system is a highway in the liver in which medication can be metabolized and then pushed out into our feces. Renal clearance is when a medication goes in and requires oxidation and then goes into the kidneys and then is urinated out. So only trace amounts of cannabis go to the urinary system, which is why THC can be tested for in a urine sample. But the majority, more than 80% of the metabolism of cannabis comes from the liver. And it has been shown to actually have a very, very low impact on the system. We've never heard of cannabis toxicity. Mostly people who have an overdose of cannabis tell us about the unhappy bus ride they're on. Well, I didn't feel great for about 4 hours and I was watching History Channel for 3 of that and it was very funny and I can't explain why. Well, we now know what we don't want to feel and we'll stay beneath that dose. But in terms of metabolism, it wouldn't react with anything that's renally cleared.
Thank you. I'm wondering if, Nicoletta, there was a question that was submitted in advance. I think it was question number 6. Nicoletta, would you like to answer that?
Yes, Nicoletta, please.
Yes. Thank you, Sandy. The question number 6 was, other than pain management, are there any upcoming cures? Number 1, we can fix existing EDS coexisting condition, such as through a surgery, craniocervical instability, a dislocated joint, ruptured ligament, or tendon inguinal hernia, and lifestyle changes provided by physiotherapists who focus to help people restore physical functions, by occupational therapists who focus on how that function affects the ability to do the things that are important, excuse me, and physiatrists who are medical doctors who focus on diagnosing, preventing, and treating all types of disability related to brain, nerve, bone, and muscles. Number two, we cannot cure and fix the EDS itself that affects the entire body because it's a genetic disease with mutations in at least 19 genes. Gene therapy, it's used to correct defective genes in order to cure a disease or to help the body fight it better, such as replacing a mutated gene or fixing it, which would be turning it on and off. Gene therapy is very promising on one side. Unfortunately, on the other side has some risks, such as unwanted immune system reaction, targeting a wrong cell, infection, or causing a tumor. Please see reference 23 on gene therapy from Mayo Clinic. Now, this is in general. In particular, answers to questions about the process of gene therapy in Canada, please see reference 24. It's a recent document published in 2020, and the title is From Research to Reality. The expert panel on the approval and use of gene therapy in Canada. EDS Society in 2019 started recruiting 1,000 participants for an international genetic study called HEDGE, Hypermobile Ehlers-Danlos Genetic Evaluation. And unfortunately, it takes time to find a treatment, being a cure, of fixing something that it's a drug or a gene therapy. For example, recruit these 1,000 participants who are willing to participate because many do not want to have their blood analyzed due to privacy concerns. Then these 1,000 EDS participants must meet very strict selection criteria. Then collect the data, which is blood, from 1,000 EDS participants around the world. And the EDS study started in early 2019, and now 2.5 years, just last month, they started to take blood samples. Then you need to analyze this data, the gene with mutation, and how you can trick it to find a cure. Write a report. There are several authors from different medical fields and different countries. Then publish it, and it must be peer reviewed. All of this could take up to 5 years. Clinical trials in Canada or US take 3 phases, and you need to write a report after each one, and could be 10, 15 years. If you are not successful, you need to look for another treatment, and you need to test it again in 3 phases and take everything from the beginning, could be 15 years. And this is actually the case with Alzheimer's treatment. After 20 years, they finally found a drug that is very controversial if it really does help to cure Alzheimer's. So finally, you need to receive approval for treatment from federally regulated medical bodies, be it Canada, US, or UK. So go back to the question, yes, we can fix, cure a coexisting condition of EDS, but EDS itself, unfortunately, we are not yet at this stage. Scientists are working very hard to find a cure, but it takes time, unfortunately.
Thank you, Nicoletta. It's interesting because it makes us think about our conference in 2019 when Dr. Andrew Maxwell presented, and he talked, and Dr. Pradeep Chopra also spoke about pain management. And it is really about, if we could get a 10% improvement in each of the different symptoms we're experiencing, we're a long way towards feeling having an improved quality of life, and maybe not the cure, but we're getting answers along the way. So those are the things to hold on to. And we are so much further ahead from where we were 11 years ago when the ILC started, where nobody wanted to talk about EDS, and look at what has been transpiring over the last number of years. So it's nice to see forward movement happening. I also like, Nicoletta, that you talked about OT, occupational therapy, and I'll just put a plug in. Arash, you'll be interested to know as well, we're working in a partnership with the McMaster University School of Rehabilitation Sciences, where we have Masters of OT students working with us. They're learning firsthand through the integrated programs that with our members about EDS and the different comorbid conditions. So it's
lucky them, because to have an EDS patient to learn on is the, like their kind of
mecca of pain.
Yeah, exactly. I want to say this in the most polite way, but you have so much to work on with the PT scope in EDS, which is excellent to hear.
Yeah,
what a perfect match.
Well, and to the point for Apollo, if there's an opportunity for us to participate in patient-engaged research, it would be really important. One of the questions that I'm always interested in, based on discussions with so many of our members, we want to know, is there scientific work being done to understand if a patient has the proteins and enzymes to metabolize pharmaceuticals or whatever pain management therapy that they're trying. This would, of course, eliminate the trial and error amount of time that it takes to get the proper pain management under control. So that's something to keep in mind if that's
what you're discussing there, Sandy, would be beneficial to the individual in all factions of medicine. Mm-hmm. I can't wait to have a patient present and say, well, I'm a slow P450 metabolizer. Then I know exactly how to start that individual. But you're right. That's stuff that we need to continue to learn and continue to push the envelope on.
Yeah, exactly. Sounds good. Well, you know what? We've gone past our time. So gosh, thank you so much to Nicoletta and Arash for a great presentation today. We'd love to have you back and provide more education. I am sure that the people who were here today as participants, as our attendees, where there's questions that you have, we will send you the answers to those questions in an email. And if you've got anything, any ideas that you would like to have other presentations on, we'd be happy to have to organize another session. Yes, Nicoletta.
I see a question. Somebody asked me where they can see the references. And as I indicated at the beginning of my presentation, the references are at the end of my presentation. I use 41 evidence-based articles to write my 2 pages evidence EDS overview, evidence-based overview. So when ILC IT people, I'm not an IT people, will post my EDS overview and the video at the end of my document. You scroll down references and there is a link and you can click on it and access for more detail. As you see, time is limited, so I could not write more than 2 pages and I could not talk more than EDS. It's, as I said, affects multiple organ system and has multiple comorbidities. And there is so much to be said, like the book Disjointed, it's over 600 pages. Mm-hmm. So the reference list, I hope it will help you, guide you to find answers to your questions.
Great. Thank you so much, Nicoletta, for mentioning that. And definitely we will be publishing the video presentation and also the PDF of Arash of your presentation and the EDS overview, and also the questions that were posed beforehand, those that are listed in the chat, and we'll include the answers to those afterwards. So thank you. Keep an eye out on that for in the next week or two. So thank you so much again for your time today, and we hope to see you again.
Thank you so much, and thank you, everybody. It was an absolute luxury, and Nicoletta, thank you for everything that you presented as well.
And thank you too, Arash. We learn every day something.
Yes, constant struggle to learn. I love it.
Exactly. Okay, bye for now.
Thanks, everybody. Bye-bye.
Bye.